place for them. The science tells us that they're working so far. 90-some-odd% success rate on mini implants, they're working, okay? But you know what that science is telling us? Our studies are 3 years old, right? Some of these implants that you know, the godfather of mobile biocare, Branimar, placed there since 1960s. So we have studies done, clinical trials done, meta-analyses done by people like Peterson that tell us about traditional implants, and they're looking 10, 15 years down the road. We don't have any information. I told you guys I was a pharmacist, and it's putting mini implants in right now for your patients is akin to giving a pregnant person thalidomide, okay? We didn't know what thalidomide did. We didn't know the effects of thalidomide, right? But it was a great drug at fixing nausea for women. So what happened? They gave it out without even doing any kind of research on it. Let's wait. I'm proposing to you guys, let's wait. Let's see what they can do. Let's use them judiciously in the right spot. And a patient that's got practically no bone here is not a candidate for any of these kind of implants. They need a chin block, they need a hip graft, they need something to put bone back before you can place the implant. So there's different patients based on amount of bone. So let's talk about the traditional 2-implant overdenture with zest locators. And basically you are going from here, you want to get a denture that has this, and then you would eventually replace those with inserts that are more retentive. That's the goal. In order to figure out exactly whether this patient is a candidate for 2-implant overdenture, you have to measure the existing denture. I don't recommend cutting it in half to measure it, but you have to measure it, and you have to have about 12 to 15 millimeters of space available for you. I'm going to show you a way that is done, a radiographic guide that is done traditional way, and then I'm going to show you how this case is done using Noble Guide, and you'll see the difference. So you have your model. You have to make sure that there's at least 6 millimeters of width here for the placement of the implant. You measure the midline, and then you measure about 8 millimeters this way, 8 millimeters this way. Why you measure 8 millimeters this way is because, and I'll show you in just a second, there you go. You are trying to place these implants in the lateral incisor location. The reason why you're trying to place these implants in the lateral incisor location is if you did what the mistake that many dentists do is if you place this in the canine position, you will cause several problems. If this patient comes to you later down the road and says, Doc, you know, I like the fact that it's retentive. I hate the fact that it's sitting on my tissues and my tissues are still getting sore. You don't have a way of putting any more implants in when you have the implants in the canine position. But if you have it in the lateral incisor position, then you are able to put one between them, and you're able to put one in a little bit distal to the canine position. Now you have the traditional 5-implant location where you can make that bar. Also, if you were to place initially this implant, the implants in this fulcrum line, now this is what I love about you guys. You guys know fulcrum lines better than any dentist. So if you put a fulcrum line here, and now you're moving the denture up and down, there's a huge amount of movement that happens in this area here. But if you move the implants more forward, then you remove that rocking teeter-totter back and forth kind of thing. So basically, now that you know where it's located, you use your 1.5 millimeters diameter drill, and you drill a hole in here. You grab some triad, and you form the triad around the base here, and you make notches in there. So it looks like from close up. Here's the rods that are in there. And then you put GC pattern resin around it, or any kind of material that you can light cure. You cut off the rods, and now you can use this, and basically you take a bite, and the reason why you take a bite is Mind you, let me go back here so that I don't confuse you. You cut these a little bit shorter than what it is here. You take a bite, and now this is really stable in the patient's mouth. And you take that radiograph, and now you can take a lateral step or a panoramic radiograph, and you can see, are these parallel together? Are they in the right angulation to distribute the force properly to the jaw? And nowadays we do this in the CT scan, so we have a three-dimensional image. And then you can put a little sleeve over it, and that's what the sleeve looks like. And then another sleeve comes, a guide sleeve comes and sits on top of it, and then you can again put material around it, and you light cure that. So you get this little insert area. And again, this is from the plaque